it's always good to teach people and then share their experience. Now, the learning objectives of this presentation are to discuss a little bit about preoperative evaluation, um, preoperative preparation, the role of hormonal therapy, how to select the type of operation, then whether a single stage versus two-stage repair, whether a tip repair versus other repairs, and discuss a little bit about post-operative care, post-operative complications, how to evaluate, and how to deal with them. So at the end, you can ask me questions once I finish this presentation. I'm not going into the depth of the embryology or the actual etiology of hypospadias, which you can all read in the books. This is more going to be on practical aspects of management, as well as what the postgraduates can reproduce in the exams. So hypospadias, we all know, is made of three components. The urethral opening is on the ventral surface, and there is ventral curvature known as chordae, and there is excess foreskin hood on the dorsum. The preoperative assessment is more than assessing the meatal location. We all know hypospadias is classified into three types: distal, midshaft, and proximal hypospadias. And it is not a rocket science to just say where the opening is, but we need to look at many other things. And there are certain points to consider in hypospadias. One is a bilateral palpable testis. The reason I am stressing this point is if you have a patient with the proximal hypospadias and both testes are not palpable, it is possible, and we have seen patients who are 46XX with the congenital hyperplasia, congenital adrenal hyperplasia, where they present with the XX DSD and both gonads are not palpable, and hypertrophied clitoris with an opening in the perineum looks exactly like a hypospadias. So you have to be aware of it. Even in those with the unilateral non-palpable testis, if one test is palpable and the other one not palpable, you can still have problems like mixed gonadal dysgenesis, where a cardiotaping will reveal 46XY or XO. When you have a bilateral palpable testis, it can be in the scrotum or it can be in the undescended locations, one of those locations. If that is the case, it can still be one of the cases of XY DSD, where you sometimes may have a micropenis and with the bilateral palpable and testis, undescended testis. Some of the examples include partial androgen insensitivities or 5-alpha reductase deficiency. I will not go into the full discussion of this, but what you need to be aware of is there's a thing called external masculinization score. So this is total score is 12. So there is a 3 points for labioscrotal fusion, 3 points for microphallus, 3 points for the location of the urethral meatus, and 3 points for undescended testis, 1.5 for the right, 1.5 for the left. So if somebody gets 12 points totally, then that is a male, complete male phenotype. If something is less than 7, then that means you may have to evaluate them for DSD. The other things you have to notice is penoscrotal transposition, torsion of the penis, and buried penis, then bifid scrotum, all those bifid, the penoscrotal webbing, all those things also you have to look at. Now, there are some places where they have this set up standard questionnaires or set up marking recording sheets where they look at the site of the urethral meatus. Now, one other thing is the urethral meatus can look distal before chordae correction, but after chordae correction, it can move a bit proximal, and then what was originally a distal hypospadias can become a mid-shaft hypospadias or a proximal hypospadias post chordae correction. So this you have to be aware of it. Then the type of the prepuce, some of them may be circumcised, some of them may have a very short prepuce, which may not be enough for a proper skin cover. Now, you also have to look at the shape of the glands, the width of the glands, the quality of the glands groove. Sometimes it is flat, the glands groove. Then you have to look at the amount of the chordae. We'll discuss more about it later. Then the width of the urethral plate. The urethral plate is the portion which you are going to tubularize. Then presence of penile torsion. So this is something worthwhile noting it before you actually start the procedure. Often there is a torsion towards the left side. So if you bring around your flaps on the right side, it automatically corrects it to some extent. Then you also have to look at the extent of penoscrotal transposition. Timing of surgery, I prefer to operate them around the age of 1 year. In the Western countries, the hypospadias is being operated at 6 months to 9 months of age. Um, they have a better development of the shaft of the penis, they have a better nutrition, and they heal much good even at that age. Whereas in Indian subcontinent, the size of the phallus and the urethral plate and then the nutrition of the child, everything is good only at 1 year. Now, some people ask whether it can be postponed further. It is not a good idea. There are multiple reasons for it. Some of them are psychological reasons. For example, if you do a hypospadias, you always have to consider that you may sometimes end up doing a second stage. So that is usually done after 1 year. So if you do a first surgery at 1.5 years, and then the second surgery at 2.5 years, then by the time the child goes to school, um, the child is completely normal, able to stand and pass urine like any other patient. So that gives a lot of psychological normal being for this child. Whereas if we delay it beyond 4 years and 5 years, the child has already started passing urine in a sitting position, or the child can be at the risk of teasing, and that can be a bit of social stigma because the child is not able to use the male toilet. Now, what do we do when a newborn is referred? Um, we have to counsel the parents basically. We have to explain to the parents what is expected, and we have to reassess them at the age of 6 months again. And then the reason to reassess them at the 6 months age is to see how the shaft has grown, how the glans has grown. If the glans width is poor, then you may have to give some hormonal injections. There are multiple possibilities here. You can use a testosterone, you can use a HCG. Testosterone is the usual one used. It can be used topically like as in a Cernos gel, or it can be used injectable like a testosterone depot injections. I prefer an injection, 25 milligram in a 10 kilo child, and then sometimes I end up giving 3 doses. Sometimes with just 1 dose it becomes better. So you have to reassess the condition after a month. The topical testosterone, there are some problems like you cannot titrate the dose. Sometimes they apply too much. The mother cannot apply because the mother can develop hirsutism. So the father only has to apply. So that kind of a limitation is there. And if the father doesn't come back from work, then they don't apply. So we don't know whether actually they have given the topical dose. So I always prefer to like an injectable testosterone. Again, there are some people who give 3 doses, some people who give single dose. I prefer to give it at the time of 7 month, 8 month, and 9 month, and then leave a gap of 2 months so that I can operate at the age of 1 year. The reason for the gap is I want the effect of testosterone to wane a little bit because it causes a little bit of erections as well as too much of increased vascularity. But at the same time, I want to keep the glans width and urethral plate width good during my surgery. So I don't want to delay it too much either. Another important thing is I have to give the child iron and vitamin supplements and make sure that the child is having a good nutrition, because around the time of 7 to 8 months only they start weaning this child, and then if they stop mother's milk and then start the child purely cow's milk, then they often end up having anti-deficiency anemia or malnutrition. So those are the things. The other important thing is some parents trying to nurse the child in prone position, and that is the time when they turn around. So I don't want my patients to be lying in this position during the surgery because that will jeopardize the healing. So I will particularly tell the parents not to nurse the child in this position. When they are going to sleep, they have to sleep flat, and once they develop the habit at the time of surgery, it's much easier for me. We have looked at the role of testosterone and published our results in Journal of Pediatric Urology, and we feel that testosterone actually increases the glans width, thereby reducing the complications and the requirement for a reoperation. It also improves the cosmetic outcomes and parental satisfaction. Now, the general principles of hypospadias repair include chori correction, urethroplasty, myotoplasty, and glandsplasty, and providing the skin cover. So the aims of the surgical repair are to provide a straight penis with a slit-shaped meatus, adequate caliber meatus at the apex of the glans, a conical reconfigured glans, circumcised appearance, or if the parents want a preputial reconstruction, and an acceptable cosmetic outcome just judged objectively. So we looked at this normal anatomy of boys without hypospadias. We published it in British Journal of Urology in 2007. One thing which we noticed is in normal patients, the meatus is a ventral structure. So if you look from the dorsum, you don't see the meatus. If you look from the ventrum, you see the meatus. So it's not like a gun where the opening is at the tip, but it is like a slit in the ventral aspect. And we felt that there are some proportions here. So the opening is like a ventral, the urethral, the vertical meatal length is as good as the amount of glands which is distal to the up to the corona. So we have these points, and then we looked at it again and then published in the Journal of Pediatric Urology in 2014. So these anatomical landmarks are very much like normal patients in hypospadias also. So you can see the points, like you can see the point A, point B, and point C in hypospadias patients also. The reason is when we start making incisions, we should not go beyond this point B, because if we keep on going further, then we end up producing the meatal stenosis. So that is something which is very important. And we published that the meatal marking of the meatus is essential to reduce the stenosis. So what are the things needed before surgery? I always prefer to have my patients have a preoperative enema. The reason being they should not have any straining in the postoperative period, and if the bowel is empty, then they are much better off having normal passing of stools. Although we give lactulose and other things, it's always better to start with the empty bowel. Then 2.5 times magnification loop is what I use. The types of catheter can be an infant feeding tube, usually 7 French, but I always ask my scrub nurse to have one size above and below ready. Then silicone Foley 8 French can be used. These are all for a 1-year-old patient, obviously. And then some people use urethral stent. I don't particularly use a urethral stent. I either use a silicone Foley in a distal hypospadias or an infant feeding tube in a proximal hypospadias. The reason for using the infant feeding tube is it comes out much easier than a Foley, which doesn't deflate fully well, and when you remove it, it can strain the suture line, particularly in the case of a proximal hypospadias. Now SPC, I don't do routinely SPC in distal hypospadias, but when I do a duct repair or when I do a second stage repair for a proximal hypospadias, I always do an SPC. The reason being, I want to clamp it and do a trial voiding. Sometimes they don't void, they end up in retention, and if we don't have an SPC, we are in trouble. Then I want my nurses to keep a tourniquet, bipolar diathermy, and fine forceps and scissors, some of the fine instruments. Sometimes I end up using adrenaline saline, not always. This is particularly for redo cases or proximal hypospadias. I dilute 1 ml of adrenaline in 200 ml of normal saline. This is not for injection or infiltration. This is only for having a swab on this, and then keep the swab to adrenaline saline swab to control the bleeding. My suture materials, usually it is 40 catgut for a stay suture, and after degloving, we have to apply the tourniquet and then do an artificial erection test. So we need a butterfly needle with saline for injecting into the corpora or glands to make an artificial erection test. I prefer a 70 PDS for urethroplasty, 50 Vicryl for glands closure, 40 ethylone or proline if I do a Nesbit plication, and 40 Vicryl rapid for the skin. So these are the routine materials which is written in the Cardex the day before. This is some of the hypospadias instruments. You can see that you need to buy a separate set of instruments for this hypospadias. Only then you can start hypospadias repair. So these are the instruments which I have, and these are some of them are fine Adson's forceps, fine sharp scissors, and fine hemostats. So these are all we need. In addition to that, we also need the magnification. Now sometimes the catheter won't go. This is a problem unique to proximal hypospadias, where you may encounter a Mullerian remnant at the level of the vermontanum, and the catheter preferentially goes into the Mullerian remnant. And to get the catheter into the bladder, sometimes you may have to pass a double feeding tube. The ventral one enters the Mullerian remnant, and the dorsal one usually goes into the bladder, or you can lift the area with the perineal pressure or a finger at the rectum, or you may sometimes have to use a cystoscope and then put a guide wire and then railroad the catheter over the guide wire. Now coming to intraoperative algorithm, it all depends on multiple factors, but one of the most important factor is we start with the degloving the foreskin. So once we completely deglove the penis, the skin cord is gone. At that time, we have to apply the tourniquet and then do an artificial erection test, also known as Gitti's test. So when the curvature is mild, like less than 30%, you can get away with the dorsal plication and then get it straight. Then you can proceed with the urethroplasty. So Nesbit plication is nothing but you make an incision in the tunica albuginea. It's also known as TAP, tunica albuginea plication. So we have to open the buccal fascia, expose the tunica, and then make a vertical incision which is closed horizontally. So that is a Nesbit plication. Then we also have to see again, do an artificial erection after that to ensure that the cord is gone. Now in a patient who has got a curvature more than 30 degree, you may sometimes have to decide whether you have to divide the urethral plate and then remove the chordae tissue. So there are multiple factors that determine the type of the hypospadias repair. The location of the meatus. Now coming to this location of the meatus, there are some patients with almost granular meatus with a minimal chordae and then only a foreskin hood. Can you leave them alone? Probably yes. If the meatus is little bit offshoot, you probably can leave some of the granular hypospadias alone. Now distal urethral hypoplasia, this is an entity where the skin on the urethra is paper thin. It's like transparent. So when you pass a feeding tube, you can actually see the markings and the numbers written on it through the urethra, through the skin. So that skin cannot be degloved, or when you deglove it, it just gets broken. So you have to keep laying open until you expose the normal urethra, which may be sometimes a proximal urethra. So the distal urethral hypoplasia is something which can make one mistake a hypospadias as a distal one, whereas in reality it is a proximal one. Then we also have to look at the degree of chordae after degloving, which we've already discussed. Then whether the fibrosis of the spongios on urethral plate, whether you have to excise all those things. Now the urethral groove, the quality or width of the urethral plate, usually a 1 centimeter urethral plate is a good urethral plate. This is another important factor which determines what type of repair we are going to do. Then glans width and then the plate at the glans level, this also determines. More than 14 millimeters usually a good glans width. If it is less than 14, then probably your glansplasty is under stress. Then the amount of dorsal foreskin hoop, then the pineal components like torsion, buried penis, which we have already discussed. So the hypospadias, as I said, first we have 3 types of hypospadias. Then we look at the chordae, and if there is a minimal chordae and then you have corrected with an Nesbit plication, then if it is a granular or coronal subcoronal hypospadias, you can do a magpie repair or a gap repair or a total urethral mobilization. If it is a coronal or distal penile hypospadias, then you can do a Thier's duplay or a Snodgrass repair if it is a good urethral plate. So this is for a coronal, the previous one is for granular and subcoronal. So the midshaft hypospadias also you can do a Snodgrass. Sometimes they extend it up to proximal penile hypospadias, also Snodgrass repair. But only if the urethral plate is good. If the urethral plate is poor, then I would rather go for a Matthew repair if it is a distal, like a subcoronal hypospadias, or an inlay, a snod graft kind of repair, or an onlay island flap, which is basically a flap taken from the dorsal foreskin. I'll be discussing all these procedures one by one, so don't worry. I'll come to all these things. So remember, if it is a granular hypospadias, we are going to do magpie or one of those procedures. If it is a coronal hypospadias, we can do a Snodgrass if it is a good urethral plate, and if it is a coronal and distal penile hypospadias with a poor urethral plate, we can do a Matthew or a Snodgraft or an onlay hypospadias. If it is a severe CODI, you have to divide the urethral plate. Then you have an option of doing a single stage repair or a two stage repair. Some people go only for a two stage repair. Some people prefer a single stage repair. It's entirely up to the surgeon's choice. Single stage repair is Asoka or a ducket repair or a Koyanagi repair. And two stage repairs can be a Bayer's flap or a foreskin graft with a foreskin free skin or a BRCA BMG. So a magpie repair is nothing but you make a vertical incision in the glans and then close it horizontally. Uh, so that makes the meatus come a little bit forwards. Then you do not do urethroplasty at all. You bring the glans around in such a way that the glans is refashioned. So there is a meatal advancement and only a glans plasty. There is no urethroplasty here. So this is what the difference is. This is the first time I'm actually giving a lecture without having any operative pictures or operative videos. This is because of the restrictions Facebook has. I've already put the video links. I'll again put the video links from the YouTube, which you can watch at the end. Now, the Matthew perimeatal based flap, also known as flip flap repair, is particularly useful when there is a subcoronal hypospadias with a poor urethral plate. A poor urethral plate means it is not 1 centimeter wide. So you have only 5 millimeter urethral plate, then you take another 5 millimeter by a flip flap. So this flap is taken from the portion. So if there is a 4 millimeter of advancement you have to do, then you take a 4 millimeter flap, flip it across, and then suture it on either side. So you have two suture lines here, one here, one here. So the 5 millimeter of the dorsal urethra comes from here, and then the 5 millimeter of the other part of the urethra comes from the flipped flap. So this is a perimeatal based flap. You can also provide a soft tissue cover for this. So that is a Matthew flip flap repair, which is very useful repair. Now, total urethral mobilization means this is again useful for cases where there is only a 4 millimeter of defect or 5 millimeter of I won't say it's a defect, that you have to advance only 5 millimeter. Then you probably have to take 2 centimeter of mobilization. So you mobilize the entire urethra. So urethra is a stretchable thing. So it stretches all the way up to the tip, and then you bring it to the meatus. So remember, it is 1:4. So if you have to advance it by 5 millimeter, then you have to mobilize it for 2 centimeters. So that is a total urethral mobilization. Now, Thier's duple or a gap repair, or you may even call it a simple urethroplasty, is nothing but when the urethral groove is very good. So here the urethral groove is good. So what you do is make a U-shaped incision and then just tubularize it over the feeding tube or Foley's catheter or whatever you have. So the original Thier's duple is a simple U-shaped incision and tubularization, which is very much possible in a case of a good urethral plate. Now, this is a circumcised appearance. You can also do a foreskin reconstruction if the parents want so. So in a foreskin reconstruction, what you do is you make an incision like a V-shaped incision going into the foreskin, and then you suture the foreskin back so that there is a retractable foreskin with a normal looking hood. Some parents want it. If they want it, this is possible in distal hypospadias. Snodgrass repair, also known as tip repair, tubularized incest urethroplasty, is nothing but the two steps added to the original Thier's duple. So Snodgrass in 1994 added two steps. He added a midline incision to the urethral plate, and then he added an interpreputial Datas waterproofing layer. So he added a midline incision so that the urethral plate becomes wider. So for example, if the urethral plate is around 7 millimeter, he makes an incision and then the urethral plate widens, and then it becomes tension free anastomosis. So that's what he says. Obviously, how it's going to heal, whether it is going to heal with a scarring, these are the problems, and some of them develop urethral stenosis. We'll come to that later. So the criteria to achieve a good results for a Snodgrass repair is you should have a good urethral plate. The urethral plate should be wide, like more than 1 centimeter, and the glans width should be more than 14 millimeter, and the caracody should be correctable. So if these are all there, then you can have a successful Snodgrass repair. On the other hand, if they are not there, then your Snodgrass repair may end up having a meatal stenosis or a urethral stricture or urethral stenosis. So these are the problems which are faced by the later surgeons who felt that this is a not working exactly in the way it works in the hands of the Snodgrass. So the tip repair or snodgrass repair is basically making a U-shaped incision. In addition, you make an incision in the urethral plate so that it widens. So people also started putting a little bit of skin graft from the dorsal skin there. So that is called snod graft or an inlay repair. So that is an inlay. And then you always harvest a inner preputial dartos layer as a waterproofing layer or a middle layer, and then give a covering so that prevents the fistula formation. So the main advantage of snodgrass repair is it gives a good vertical slit-shaped meatus and it reduces the fistula formation. But the problems are urethral stenosis and urethral meatal stenosis. So the intermediate layer can be from inner preputial dartos flap, or it can be from the tunica vaginalis flap. As the snodgrass repair started going to be used for even more proximal hypospadias, proximal penile hypospadias, the dartos layer is very important for the outer cover as well. So we started using tunica vaginalis flap, and we felt that in a midshaft and proximal hypospadias, if you are doing a tip repair, then you are probably better off doing a tunica vaginalis flap, which is basically a flap based on the blood supply from the external spermatic fascia. So the external spermatic fascia along with the tunica vaginalis is taken. So it is continuous blood supply from the artery to the vas and other things. Onlay island flap is a type of repair where the cord is correctable. The urethral plate is not wide. It is only like 5 millimeter. But you want to keep the urethral plate. There is no need to excise the urethral plate. So you probably have to take another 5 millimeter wide, and then whatever length, if it is like a proximal hypospadias with 1 centimeter or 2 centimeter length and 5 millimeter width, then you can take the same length and same width inner preputial skin on a pedicle. So you rotate it and then do a suturing on both sides. So half the width is from the native urethral plate, half the width is from the onlay island flap. So this is an onlay island flap which can be used for patients where a snodgrass repair is not possible. Ducket or a SOPA repair is a repair where you can have the same technique like an onlay island flap, but you have already discarded the scarred urethra. So the urethral, there is a fibrosed spongiosa, or the urethral plate itself is fibrosed. So you keep on excising until the cord is fully corrected. Sometimes you may have to do a multiple corporotomies to make a release of that ventral curvature. And then once that is done, you rotate the skin. You probably have to take a wider skin in this case, and then make a tube out of it, anastomose the tube to the proximal end and distal end. So that is a ducket or a SOPA repair. Two-stage repairs, some surgeons prefer a two-stage repair. They want to have a good peaceful sleep by not doing the single-stage repairs. So they are quite okay to do that. Sometimes in a severe hypospadias, maybe with a penoscrotal transposition, it's probably a good idea to do a two-stage repair. So two-stage repair, the commonest repair which is being done in the Indian subcontinent is Bayer's flap. So what I mean by Bayer's flap is, as I said, we release the cordy, and then after degloving the penis, there is still some cordy. So we keep on excising the urethral fibrous tissue, the spongiosa, everything until the meatus becomes proximal. Then the degloved foreskin is divided dorsally at 12 o'clock. Then you have two flaps. You bring the flaps to the midline and then suture it there. So that is the first stage of the Bayer's flap repair, and then you leave it like that to heal for 6 months, and then you have to warn the parents that this patient will be still hypospadiac, and then after 6 months to 1 year you go back, make a U-shaped incision, make a tube out of it, and then this time you can provide a tunica vaginalis flap and then cover the hypospadias repair. So that is a Bayer's flap. It gives a very good cosmetic appearance, quite a long penis, because some of the single stage repairs you end up leaving a little bit of cordy, whereas here complete cordy is corrected. So that is the advantage of a two-stage repair. Now in the Western countries, they don't like the Bayer's flap, so they take a free foreskin. So the foreskin is completely taken free, like a full thickness skin without any fat. So they defat the foreskin and then apply it like a graft, and then quilt it, and then wait for it to take it nicely, and then after 6 months they go for a urethroplasty. So the tubular resection is done later. So that is a typical two-stage repair, first stage and two-stage done in the Western world. Two-stage BRCA, this is typically useful for a failed hypospadias, when somebody has got a multiple fistula, scarring, previous failed surgery. So you have to excise all those scar tissues, and then get a noise, go up to the normal urethra, then you leave a buccal mucosa or labial mucosa, quilt it, then after 6 months to 1 year, you can come back and then make a tube out of it, maybe give a middle layer also. That's a two-stage BRCA repair. Post-operative care, the type of the dressing, it can be a sandwich dressing, like two tegaderms applied, or an occlusive dressing with a dynaplast, or something which is strapped to the abdomen like a flower-shaped dressing. It can be with a simple white plaster, or it can be with the dynaplast. For a distal hypospadias, usually a tegaderm dressing is enough. For proximal hypospadias, you probably need a proper dressing. The timing of the catheter removal, usually it is 7 to 10 days. They are often done as a daycare procedure. So you just give a single dose of IV antibiotic, and then the rest of it is as like oral antibiotics. I always prefer them to have anticholinergics and laxatives to prevent bladder spasms and constipation. The dressing is often not changed in children for 7 to 10 days. Some of the problems can be soaking, pericatheter leak if they are straining to pass urine, or during passing of stools. Sometimes the catheter slips out if your dressing is not proper, or it gets wet, or sometimes the catheter kinks and blocks. So all these things the parents have to be warned when they go home. We have to tell them how to take care of the catheter without getting it blocked, without the child straining for stools, because every little bit is important in addition to taking a meticulous surgical technique. Complications, hypospadias is well known to have complications, and one should not get disheartened. In fact, one should actually warn the parent about the complications, like which is pretty high, 5 to 25%. It can be a urethroputaneous fistula, meatal stenosis, urethral stenosis, glands dehiscence, urethral diverticulum, cosmetic issues like excess skin, skin tag, inclusion cyst, skin bridges, or suture tracts. The reason I'm stressing on this is these things are not considered as a complication by the surgeon, whereas when the patients are asked, they have a lot of problem with the self-image due to this little skin tag or an excess skin or a suture tract. They give a lot of value to all these things. Then hair-bearing urethra can be an issue if you are using the more proximal urethral skin. Then recurrent curvature or a buried penis later on appearing like a trapped penis. All those things can be some complications. Meatal stenosis is particularly because you have taken the incision too far distally. Like what I told you, you have taken beyond the point B towards the point A. So you want to make a meatus more and more distal. You end up having a meatal stenosis. Or if the glans plasty is too tight, the glans is not wide enough, then you may end up having a meatal stenosis, like a flat glans or a poor urethral groove. So these are the conditions. You may have to do a meatal dilatation, or a meatotomy may be sufficient in some cases. In more complex cases where there is a distal stricture also involving the meatus and the distal urethra, you have to lay open the entire thing and then put a buccal mucosa graft and then come back another day. Fistula is the one complication which bothers the surgeon. It is often reported by the parent as either two streams or a stream and a few drops coming from one place. It's very difficult to notice the fistula on examination. You have to ask the patient to void and then inspect when the voiding is happen, and that is when you confirm the presence of fistula. A fistula may result from a distal stricture or a meatal stenosis. It may be because of a poor technique. You have not taken the bites properly, or you have taken it, devitalized the tissues, or it can be because of absence of second layer like a waterproofing layer. Glans dehiscence, it's mainly because the glans width is not good. It is too tight. The management is, if there's a minimal glans dehiscence, you end up having a glandular meatus. You can probably reissue them and leave them. But if there is a glans bridge with two streams, then you probably have to redo repair like a Matthew repair or a urethral advancement, And if it is a poor, it's a big dehiscence and then poor cosmetic outcome, then you may have to lay open and then do a buccal mucosa graft. Urethral diverticulum is a particular problem following onlay repair or a duct repair. It can be a small one. In those conditions, all they have is like after passing the urine, they will still have some drops dribbling from the thing. Over a period of time, it may get better. So if a small diverticulum can be managed expectantly, if there is a distal obstruction in the urethra, you can do an OIU sometimes. A large diverticulum probably needs excision and a urethroplasty with some kind of flap to cover to prevent fistula formation. Structure urethra is particularly following a tip repair with those pore plate, or in those with the proximal hypospadias where the anastomotic site can become develop a stricture. The management, if it is a poor stream and uroflow, if it is a short segment stricture, then you can do a OIU. If it's a long stricture, again you have to excise the graft and then go for a second stage repair. Total breakdown is very rare. This is essentially problems with using too much of electrocautery or devascularization of the flap. This is a rare problem. Then hypospadias cripples. This is particularly a term used for multiple unsuccessful hypospadias repair with a significant pineal deformity or watering can perineum, sometimes it is called. They always need a buccal mucosa graft repair after excising all the scar tissue. Cosmetic outcomes, surgeon's perception can be different, parents' perception can be different, and the patient's perception can be different. There are multiple scoring systems like a HOSE or a HOPE score, and these scoring systems are useful for objective evaluation of a patient rather than just saying that everything is fine. Then photographic assessment, preoperative and post-operative photographs have been applied by Lawrence Baskin and others. This is a hypospadias objective evaluation, scoring evaluation, where there are points given for meatal location. If the meatus is retracted to some of these positions, then you get these points. Then the meatal shape has got some points. Then urinary stream, how the stream, whether it is spraying, whether the meatus is vertical or circular, they have got different points for it. And then how many openings are there, whether the penis is straight, the type of the fistula, all those things have got different points to score them objectively. Some of the long-term issues are erectile dysfunctions, ejaculatory difficulties, lower self-esteem, the negative genital perception. Overall sexual function is actually okay, maybe slightly less, but they are okay. When adults were asked a questionnaire about what was their experience with the hypospadias repair and how they feel, 5% had dissatisfaction with the appearance of the genitals, 32% were unaware that they had an anomaly, a third of the patients had voiding issues, and 5% of them still stacked a void. Now, sometimes we do get patients who are like 20 years old or 25 years old and adult hypospadias. There are certain points one has to remember in a patient with an adult hypospadias. They need a larger caliber urethra. So you probably have to choose the catheter appropriately. Then I always tend to leave the catheter for 14 days, not just 7 to 10 days, because they take a longer time to heal. And I always consider an SPC in an adult hypospadias because you always have to do a trial voiding, and the trial voiding often fails in an adult because they have this inhibition to void. Antibiotics, they have a higher rate of infection because of the sebaceous secretions as well as seminal secretions, and they need to give a higher antibiotics for them for a longer duration. And the dressing also gets quite smelly and then soiled. While in a child, I may not change the dressing for 7 to 10 days without any problems. An adult hypospadias may need a frequent dressing change because it just gets smelly. And you may need to give medication to suppress nocturnal erections in adult patients, in addition to giving them sedations and anticholinergics. So to summarize, hypospadias ideally is operated around 1 year of age. You always warn the parents about the complications or the need for the second stage. If it is a proximal hypospadias, it is going to be a planned second stage, if you can tell, or you can tell that only on the table you can decide. You cannot assess the severity before degloving, so that means you cannot promise. So you have to tell the parents upfront that you may have to do a two-stage procedure, or you can have the second stage for the fistula. It is always better to upfront explain that there is a fistula chance. Then better to be well versed with more than one technique. Then staging of the repair should not be considered as a failure, and then whenever it is needed, it should be considered. Then preoperative preparations, meticulous surgical technique, utmost post-operative care, and nutrition of the child. Every little bit is essential to get a successful outcome. So that's all about hypospadias.